When we look at a patient prepared for craniotomy, we often see a checklist of isolated gadgets. But in reality, this is a unified support system. Every sensor we place, from the head to the feet, has a single, converging purpose: putting the brain in the best possible situation for the operation to run safely and effectively. To understand this, we have to break the standard monitoring list down. Starting with the heart. With ECG, we monitor its chronotropic and inotropic state using the ECG. We use this to track the rate and to actively detect ischemia. Once the heart is monitored, we must verify the pressure it delivers by using invasive arterial line. Physically, we place the arterial line here in the radial artery for beat-to-beat feedback to prevent a sudden drop in perfusion. Crucially, we zero the transducer at the level of the foramen of Monro, approximated by the ear. This line is also used for arterial gas analysis, PaO2, PaCO2, and the pH of the blood. 3. Spirometry and gas analysis, moving from the circulation to the respiratory system. We utilize side-stream spirometry to monitor volume and flow. Simultaneously, we rely on airway gas analysis to track inspired oxygen, end-tidal O2, and anesthetic agent concentration. We also monitor the endotracheal cuff pressure. If the tube moves or the patient bucks because of a light block, intracranial pressure spikes instantly. And within that airway circuit, we find our most powerful tool for volume control. 4. End-tidal CO2. The ventilator is not just oxygenating the blood, it is the remote control for the brain's physical size. Since carbon dioxide is the most potent vasodilator of cerebral vessels, we watch the end-tidal CO2 like a hawk to control intracranial volume. The excretion. We manage fluids tightly because fluid overload equals cerebral edema. The hourly urine output is our reality check. It tells us if the kidneys are perfused. If the kidneys are happy, the cardiac output is generally sufficient. 6. Core temperature. We monitor core temperature in everyone. Typically, we let patients drift slightly hypothermic to lower the brain's metabolic rate, which acts as a vital neuroprotector. To maintain this stable environment and prevent patient movement. 7. Neuromuscular monitoring. We utilize neuromuscular monitoring. Crucially, we monitor the non-paretic arm to avoid false readings, ensuring the patient is fully paralyzed so the brain stays completely relaxed. However, if the standard measures aren't enough. 8. Advanced flow. If the patient is hemodynamically unstable, we may escalate to advanced flow monitoring, like PICS-CO. This allows us to optimize cardiac output with greater precision, as it provides dynamic data on preload, contractility, afterload, and extravascular lung water. Finally, in specific positions, we must hunt for silent killers using 9. Precordial Doppler, here in the thorax. In the sitting position, the dural sinuses are above the heart, creating a vacuum. We place the precordial Doppler over the right sternal border to listen to the right atrium. This is our acoustic shield. It hears air bubbles, venous air embolism, long before the end-tidal CO2 drops or the blood pressure crashes. When viewing this map, note that we monitor the brain's environment, not individual organs, to ensure its needs are met.